Seniors, look closely at your medicine cabinet. What if the very pills you trust to keep you healthy are secretly shrinking your brain? Doctors and pharmaceutical companies have known about this hidden danger for years, and 99% of seniors are taking at least one of these 9 medications right now. Don't touch another pill until you know which ones dramatically increase your risk of rapid dementia. Stay with us. This is the information that could literally save your mind. But before we dive into the discussion, please share your age, country where you live, and any health issues you're experiencing that you'd like us to discuss. Write down in the comments section below so we can address them together. And don't forget to hit that subscribe button and share this video to help spread these benefits to our community and others who need it. The increasing prevalence of cognitive impairment and Alzheimer's disease in the aging population has prompted rigorous investigation into its etiology, extending beyond traditional genetic and lifestyle factors. Emerging scientific consensus highlights a critical, yet often overlooked, contributor: pharmacotherapy. This chapter delves into the concept of a silent epidemic, where medications, routinely prescribed and consumed by the elderly for chronic conditions, may be inadvertently accelerating the rate of cognitive decline. Specifically, we examine the neurobiological impact of polypharmacy, the simultaneous use of multiple drugs, and the cumulative effect it has on central nervous system function. Research indicates that certain classes of pharmaceuticals interfere with key neurotransmitter systems, diminish cerebral blood flow, and hinder the brain's ability to clear toxic proteins, collectively creating a neurotoxic environment. This discussion is not an indictment of necessary medication, but rather an evidence-based exploration into the pharmacological landscape of aging, providing a foundation for understanding how therapeutic necessity must be carefully balanced against the measurable risk of compromising long-term cognitive integrity. This phenomenon necessitates a paradigm shift in geriatric care, emphasizing vigilance in medication management to mitigate what may be a preventable pathway toward cognitive impairment. In the standard clinical setting, the primary focus of medication prescription is the immediate and effective management of a target symptom or chronic disease, such as hypertension or chronic pain. However, a significant gap often exists in communicating the full spectrum of long-term cognitive side effects, particularly those that manifest subtly over years and mimic the initial stages of natural aging or early-onset dementia. This chapter explores the mechanism of what is scientifically termed drug-induced cognitive risk, DICR, distinguishing it from temporary delirium or acute confusion. DICR stems from 2 primary pharmacological pathways. First, direct interference with critical neurotransmitter systems responsible for memory and executive function, and second, disruption of metabolic processes, such as nutrient absorption or mitochondrial health, essential for neuronal vitality. We will analyze how the systemic slow erosion of brain function, often perceived by patients and families as simple forgetfulness or senior moments, can in reality be a direct, dose-dependent consequence of long-term medication use. Understanding the specific pharmacological characteristics that predispose a drug to cause DICR is vital for patient advocacy, necessitating a proactive approach to discussing and questioning the necessity of every long-term prescription with healthcare providers. This knowledge empowers patients to differentiate between natural progression and preventable, chemically accelerated decline. The term anticholinergic refers to a diverse group of medications that share a common mechanism, blocking the action of acetylcholine, a crucial neurotransmitter in both the central and peripheral nervous systems. Acetylcholine is indispensable for numerous cognitive processes, including memory formation, particularly in the hippocampus, sustained attention, and executive function. This chapter provides a detailed neuropharmacological perspective on why anticholinergic drugs constitute a high-risk class for the elderly. By competitively inhibiting muscarinic acetylcholine receptors, these medications effectively dampen neural signaling, leading to measurable short-term side effects such as confusion, dry mouth, and blurred vision. Crucially, prolonged cumulative exposure, especially the exposure conferred by high anticholinergic burden, ACB scores, has been definitively correlated with structural changes in the brain, including reduced volume in key memory centers. We will review compelling longitudinal studies, demonstrating that this chronic blockade can significantly accelerate the pathological processes that underlie dementia. Given that many common medications for sleep, allergies, bladder control, and mood possess anticholinergic properties, recognizing and quantifying this cumulative burden is the single most important step in mitigating the risk of drug-induced cognitive acceleration. To standardize best practices and improve medication safety in the geriatric population, the American Geriatric Society, AGS, developed and regularly updates the Beers criteria. This comprehensive list identifies medications that are potentially inappropriate for use in older adults due to a high risk of adverse drug events, ADEs, including those leading to cognitive impairment. This chapter focuses on the clinical significance and utility of the Beers criteria as a foundational tool for both practitioners and patients seeking to minimize cognitive risk. Many of the medications flagged in the Beers criteria are highlighted precisely because of their potent anticholinergic activity or their association with severe sedation and falls, factors which profoundly compromise cognitive health and functional independence. We will analyze the specific categories of drugs listed, such as certain antipsychotics, benzodiazepines, and tricyclic antidepressants, that should be either avoided entirely or used with extreme caution and at the lowest effective dose for the shortest duration possible in individuals age 65 and older. Adherence to these criteria is not merely a recommendation. It is an evidence-based strategy to proactively prevent drug-induced morbidity and mortality, making it a crucial benchmark for identifying prescriptions that pose an undue risk to long-term cognitive vitality. While the anticholinergic properties of a single medication present a measurable risk, the most significant pharmacological threat to the aging brain is a condition known as anticholinergic polypharmacy, or high anticholinergic burden. This chapter defines and examines the catastrophic synergy that occurs when an older adult simultaneously consumes multiple medications, each with its own anticholinergic score, from different therapeutic classes. The central danger lies in the fact that healthcare providers often treat individual symptoms in isolation. One physician prescribes an anticholinergic for overactive bladder, another for insomnia, and a third for pain, unknowingly creating a toxic, cumulative effect. When combined, these medications don't just add their anticholinergic effects, they multiply them, leading to a dose-response relationship where the total burden dramatically accelerates cognitive decline. We will explore epidemiological studies, such as the 2022 analysis cited in Age and Aging, which found that the highest anticholinergic burden scores were associated with a staggering 120% increased risk of developing dementia. This evidence strongly shifts the focus from avoiding a single bad drug to meticulously auditing the patient's entire pharmacological profile, emphasizing that the cumulative chemical effect, rather than any isolated prescription, represents the single greatest preventable risk factor for drug-induced cognitive impairment. Antipsychotic medications, including agents like quetiapine, Seroquel, and risperidone, Risperdal, were originally developed and approved for the treatment of severe psychiatric disorders, such as schizophrenia and bipolar disorder. However, a highly concerning practice has become widespread in geriatric care, particularly in nursing home and institutional settings. The off-label prescription of these powerful drugs to manage non-psychotic symptoms in the elderly, such as agitation, restlessness, and sleep disturbances, often associated with dementia itself. This chapter critically analyzes the profound neurobiological risks associated with this practice. Antipsychotics primarily function by modulating dopamine receptors, a neurotransmitter critical not only for mood and motivation, but also for executive function, motor control, and memory processing. The suppression of the dopaminergic system in a non-psychotic elderly patient often results in a state of chemical sedation, leading to emotional flattening, personality changes, motor slowing, and a noticeable blunting of cognitive responses, a state often described by family members as zombification. Compounding this, studies including a 2022 analysis in the Lancet Healthy Longevity have demonstrated that seniors prescribed these drugs for behavioral symptoms were significantly more likely to experience worsening cognitive decline and had increased risks of stroke and sudden death. This practice transforms these medications from therapeutic agents into chemical restraints, underscoring the urgent need for non-pharmacological interventions as the preferred strategy for managing behavioral symptoms in dementia. Selective serotonin reuptake inhibitors, SSRIs, are widely considered first-line treatments for depression and anxiety, often favored for their generally lower side effect profile compared to older antidepressants. Within the SSRI class, however, one agent stands out as a significant cognitive hazard, particularly for the elderly: paroxetine, Paxil. This chapter details the neuropharmacological anomaly of paroxetine. It is the only commonly prescribed SSRI that exhibits substantial anticholinergic properties. While most SSRIs primarily affect the serotonergic system, paroxetine also possesses a clinically relevant affinity for muscarinic acetylcholine receptors, thereby combining the effects of serotonin modulation with the memory-impairing effects of acetylcholine blockade. For older adults with an already fragile cholinergic system, this dual action can be uniquely detrimental. We will review clinical data, such as a 2021 review in Frontiers in Psychiatry, which observed that elderly patients taking paroxetine showed measurable declines in short-term memory, verbal recall, and attention span compared to those on other SSRIs. This finding justifies the classification of paroxetine on the AGS-Beers criteria as a potentially inappropriate medication for the elderly. For patients requiring pharmacotherapy for mood disorders, substituting paroxetine with non-anticholinergic alternatives like sertraline or escitalopram represents a straightforward, evidence-based strategy to mitigate preventable cognitive decline. Amitriptyline, marketed under brand names like Elavil, is a tricyclic antidepressant, TCA, that, despite being a medication from an older generation, remains widely prescribed today for a range of conditions including nerve pain, chronic insomnia, and migraine prophylaxis. This chapter examines the critical danger this specific drug poses to cognitive health due to its status as one of the most potent anticholinergic medications still in common use. Amitriptyline's mechanism involves an intense blockade of acetylcholine, often far exceeding the effects of newer anticholinergic agents. While this action may be therapeutically effective for certain pain pathways, its effect on the brain is profoundly detrimental. We will discuss the findings of large-scale epidemiological studies, most notably a landmark 2015 study published in JAMA Internal Medicine, which demonstrated a clear link between the cumulative dose of anticholinergic medications like amitriptyline and long-term dementia risk. Specifically, adults aged 65 and older who took higher cumulative doses over a 10-year period faced a 54% greater chance of developing dementia. The insidious nature of this risk is that patients, often prescribed a low dose for sleep or chronic pain, may experience a slow, invisible erosion of memory and concentration that is mistakenly attributed to natural aging when it is, in fact, chemically induced. This mandates an urgent reassessment of amitriptyline's risk-benefit profile in all older patients, favoring alternatives that do not carry such a severe cholinergic burden. Benzodiazepines, a class of psychoactive drugs encompassing agents such as lorazepam, Ativan, diazepam, Valium, and alprazolam, Xanax, are among the most frequently prescribed medications for acute anxiety, panic disorders, and short-term insomnia. While they provide immediate relief by enhancing the inhibitory effects of the neurotransmitter GABA, gamma-aminobutyric acid, their long-term use in older adults poses a serious and well-documented risk to cognitive integrity. This chapter explores how chronic benzodiazepine use induces a state of chemical sedation that slows down neuronal activity across critical brain regions. The enhanced GABA-ergic inhibition leads to decreased neural flexibility and reduced efficiency in forming and retrieving memories. Longitudinal studies, including a 2022 analysis published in the BMJ, have established a strong association between prolonged benzodiazepine use, exceeding 3 months, and a significantly increased risk of developing Alzheimer's disease, In some analyses, the risk was elevated by over 50%. This risk is often compounded by physical dependence, where attempts to discontinue the drug lead to severe withdrawal symptoms, anxiety, agitation, insomnia, that paradoxically reinforce the patient's reliance on the very medication contributing to their cognitive decline. Therefore, the long-term management of anxiety and sleep in the elderly should pivot away from these habit-forming, memory-impairing agents toward non-pharmacological therapies or safer, non-sedating pharmaceutical alternatives. Statins are one of the most widely prescribed drug classes globally, primarily utilized for lowering low-density lipoprotein, LDL, cholesterol levels to mitigate the risk of cardiovascular events like heart attacks and strokes. However, this chapter explores the complex and often contradictory relationship between statin therapy and brain health. While reducing systemic cholesterol benefits vascular health, a critical paradox arises in the brain. The central nervous system is composed of nearly 60% fat, and cholesterol is absolutely essential for maintaining the integrity and function of neurons. Specifically, cholesterol is a key component of the myelin sheath, the fatty protective coating that ensures rapid and efficient nerve signal transmission. By aggressively inhibiting cholesterol synthesis, some statins, particularly those that easily cross the blood-brain barrier, like simvastatin and atorvastatin, may inadvertently deprive the brain of the necessary building blocks for neuronal maintenance and repair. We will examine scientific literature, including studies published in Frontiers in Aging Neuroscience, suggesting that prolonged statin use may be associated with an increased risk of mild cognitive impairment, MCI. The crucial distinction lies in the lipophilicity of the statin. Water-soluble agents like pravastatin and rosuvastatin are generally considered less likely to cross the blood-brain barrier and, therefore, may present a reduced cognitive risk compared to their lipid-soluble counterparts. This necessitates a personalized risk-benefit assessment that considers the patient's cardiovascular risk alongside their current cognitive status. The challenge of managing an overactive bladder, OAB, and urinary incontinence often leads physicians to prescribe anticholinergic medications like oxybutynin, ditropan, to older adults. These drugs function by relaxing the bladder muscle, thereby reducing the urgency and frequency of urination. However, this therapeutic benefit comes with a significant, often unacknowledged, cognitive cost. This chapter details why oxybutynin is a high-risk medication for the elderly brain. As a potent anticholinergic agent, oxybutynin readily crosses the blood-brain barrier and directly interferes with acetylcholine receptors in the hippocampus, the brain's central memory hub. The efficacy in bladder control is achieved through the same mechanism that impairs memory formation and recall. We will reference studies such as the 2019 data published in the BMJ, which established that individuals over the age of 65 taking strong anticholinergics like oxybutynin for more than 1 year had a substantially elevated risk of developing dementia. The resulting cognitive impairment, characterized by fog, disorientation, and short-term memory lapses, is frequently misinterpreted as a natural consequence of aging rather than a side effect of the bladder medication. The critical clinical imperative, therefore, is to explore newer, non-anticholinergic alternatives, such as mirabegron, which utilize a different mechanism of action and pose a significantly lower risk to the patient is long-term cognitive health. Proton pump inhibitors, PPIs, including common agents like omeprazole, Prilosec, and esomeprazole, Nexium, are among the most frequently prescribed drugs globally used for the long-term management of gastroesophageal reflux disease, GERD, ulcers, and severe heartburn. These medications operate by aggressively suppressing the production of stomach acid, providing effective symptomatic relief. However, this chapter focuses on the secondary, yet profound, neurocognitive risk associated with chronic acid suppression. Stomach acid is indispensable for the release of vitamin B12 from the food protein matrix, allowing it to be subsequently absorbed in the small intestine. By reducing gastric acidity too dramatically, PPIs impede this crucial step, leading to impaired B12 absorption. Vitamin B12 deficiency is a well-established cause of peripheral neuropathy and, critically, cognitive impairment, confusion, and memory loss that can mimic or accelerate dementia. Furthermore, chronic PPI use has also been implicated in hindering the absorption of other vital brain nutrients, such as magnesium and calcium. We will review epidemiological evidence, including a 2016 study in JAMA Neurology, which demonstrated a link between regular PPI use and an increased risk of dementia. This mechanism highlights a critical metabolic pathway to cognitive decline that is entirely distinct from anticholinergic effects, mandating that patients on long-term PPI therapy be regularly monitored for B12 status, and whenever clinically appropriate, transitioned to less invasive alternatives like H2 blockers or non-pharmacological therapies. Diphenhydramine, the active ingredient in common over-the-counter OTC allergy, cold, and most crucially, sleep aid medications, often marketed with PM or nighttime labels, represents a significant and often underestimated source of cognitive risk for the elderly. Many older adults turn to these readily available products for nocturnal restlessness, unaware that they are consuming a potent anticholinergic agent. This chapter illuminates the dangers of self-medication with diphenhydramine. Like other anticholinergics, diphenhydramine crosses the blood-brain barrier and directly antagonizes acetylcholine receptors, disrupting the delicate balance necessary for both restorative sleep and efficient memory consolidation. Critically, because these drugs are available without a prescription, their consumption is rarely tracked by physicians, leading to an invisible contribution to the overall anticholinergic burden, ACB score. Studies, including those cited in the Journal of Geriatric Cognitive Health, have linked regular use of anticholinergic drugs, like diphenhydramine, to a significantly higher risk of developing dementia. The irony is that the temporary sedation offered by these agents does not equate to genuine restorative sleep. Instead, it often induces a state of chemically mediated drowsiness that impairs daytime clarity and accelerates cognitive decline. Education is paramount, as the perceived safety of an OTC status does not negate the profound neurotoxicity, underscoring the need for non-sedating alternatives, such as newer antihistamines or structured sleep hygiene techniques, to safeguard the aging brain. Given the insidious nature of drug-induced cognitive risk, DICR, and the widespread issue of polypharmacy in the elderly, the most crucial and proactive step an individual can take is to initiate a comprehensive medication review, CMR. This chapter outlines the necessity, process, and expected outcomes of a thorough CMR, positioning it as the primary strategy for mitigating pharmacological harm. A CMR is a systematic evaluation conducted by a qualified healthcare professional, typically a pharmacist or geriatrician, that goes far beyond merely checking for drug-drug interactions. Its core purpose is to calculate the patient's total pharmacological burden, specifically focusing on the cumulative anticholinergic burden, ACB score, and identifying medications flagged by the AGS-Beers criteria. The review involves gathering a complete inventory of all consumed substances, prescription drugs, past and present, over-the-counter medications, and dietary supplements. The goal is to identify medications that are unnecessary, duplicative, at too high a dose, or pose a disproportionate cognitive risk, particularly when safer alternatives exist. Patients should be prepared to ask specific, assertive questions during this review, such as, what is the anticholinergic score of my current regimen? And are there any drugs I am taking that are flagged as potentially inappropriate for my age group? This process shifts the focus from passively taking medications to actively managing a therapeutic plan designed to support, not compromise, long-term cognitive vitality. Deprescribing is defined as the planned and supervised process of dose reduction or complete cessation of medications that may be causing harm or are no longer beneficial. This chapter asserts that deprescribing is not merely a reactive measure against adverse events, but a proactive, evidence-based strategy, essential for restoring and safeguarding cognitive function compromised by high-risk drugs. The necessity of this process stems from the principle that for many elderly patients, the risks associated with certain long-term medications, particularly those with high anticholinergic burden or sedative properties, eventually outweigh the intended therapeutic benefits. We will detail the critical importance of a gradual, medically supervised tapering schedule for classes such as benzodiazepines and tricyclic antidepressants. Abrupt cessation can trigger severe and potentially dangerous withdrawal syndromes, e.g., rebound anxiety, seizures, or acute delirium, that can further destabilize the patient's cognitive and physiological state. The successful deprescribing process requires close collaboration between the patient, their family, and a multidisciplinary care team, involving the identification of a target drug, the establishment of a slow reduction protocol, and continuous monitoring for symptom recurrence or withdrawal effects. When executed correctly, deprescribing often leads to measurable improvements in alertness, memory, and overall quality of life, demonstrating the powerful and often reversible nature of drug-induced cognitive impairment. The primary resistance to deprescribing high-risk medications often stems from the fear of symptoms returning, necessitating a comprehensive understanding of effective and neurologically safer alternative therapies. This chapter shifts the focus from managing conditions with drugs that carry significant cognitive risk to utilizing modern or non-pharmacological approaches. For chronic pain management, where highly anticholinergic tricyclic antidepressants are often used, safer pharmaceutical options include agents like duloxetine or gabapentin, which operate through different neurological pathways with a significantly reduced impact on cholinergic signaling. For sleep disorders, the move should be away from sedating anticholinergic OTC aids and benzodiazepines towards structured sleep hygiene protocols, melatonin supplementation, or potentially very low-dose, short-acting hypnotic agents when necessary, provided they are not flagged by the Beers criteria. Managing anxiety, a common indication for long-term benzodiazepine use, can often be effectively accomplished with buspirone, a non-sedating anti-anxiety agent, or via non-pharmacological interventions such as cognitive behavioral therapy, CBT, and mindfulness training, which address the root cause of anxiety without inducing chemical sedation or compromising memory function. By prioritizing strategies that support the brain's natural chemical equilibrium, patients can achieve therapeutic relief without incurring the preventable risk of accelerated cognitive decline. While the preceding chapters have focused on the dangers of pharmacological agents, this chapter explores the crucial role of nutrition and targeted supplementation as a proactive measure to support and restore brain health, particularly in the context of reducing drug-induced cognitive risk. The focus is placed on essential micronutrients, especially the B vitamin complex, which are indispensable cofactors in numerous neural processes. Vitamin B12, B6, and B9 folate are vital for the synthesis of neurotransmitters, the maintenance of the myelin sheath, and the regulation of homocysteine levels, an amino acid whose elevated presence is a known risk factor for vascular and cognitive decline. We will emphasize the specific vulnerability of the elderly to deficiencies, particularly B12 deficiency resulting from conditions like chronic proton pump inhibitor, PPI use, or age-related decline in stomach acid production, atrophic gastritis. Supplementation, especially with the active methylated forms of B vitamins, can be an effective, low-risk strategy to naturally support neuronal vitality, enhance energy metabolism, and help mitigate the foggy symptoms associated with nutrient depletion. Additionally, we will briefly touch upon other non-drug compounds, such as deglycyrrhizinated licorice, DGL, for supporting gastrointestinal health without suppressing acid, as part of a holistic approach to maintaining a brain-friendly chemical environment. For many older adults, the diagnosis of chronic gastroesophageal reflux disease, GERD, has resulted in years or even decades of uninterrupted use of proton pump inhibitors, PPIs, such as esomeprazole, Nexium, or omeprazole, Prilosec. Given the documented risk of nutrient malabsorption, particularly vitamin B12, and the associated elevated risk of dementia, discontinuing or reducing PPI dependency is a crucial cognitive safeguarding strategy. This chapter provides a clear, evidence-based protocol for the PPI tapering strategy. Abrupt cessation of PPIs is highly discouraged, due to the likelihood of severe rebound acid hypersecretion, which causes symptoms worse than the original condition, often compelling the patient to restart the drug. Instead, the strategy involves a gradual step-down, often switching from the potent PPI to a less invasive class of acid suppressants, specifically H2 receptor blockers, H2RA, like famotidine, Pepside. The protocol generally begins with reducing the PPI dose, then cycling the PPI, e.g., taking it only every other day, while simultaneously introducing the H2RA to manage breakthrough symptoms. H2RAs are generally considered to have a lower risk of long-term nutrient interference and cognitive side effects than PPIs, making them a preferred bridge medication. The ultimate goal is to transition the patient to the lowest effective dose of an H2RA, or ideally, to non-pharmacological, lifestyle-based GERD management strategies, thereby mitigating the ongoing metabolic risk to the brain while controlling symptoms effectively. Given the significant cognitive risks associated with long-term use of sedative and anxiolytic medications, particularly benzodiazepines and anticholinergic sleep aids, non-pharmacological interventions are increasingly recognized as the gold standard for managing chronic insomnia and anxiety in the elderly. This chapter focuses on the evidence-based utility of cognitive behavioral therapy, CBT. Specifically tailored programs like CBT for insomnia, CBTI, and CBT for anxiety, CBTA. CBTI addresses the psychological and behavioral factors perpetuating chronic sleep difficulties, focusing on sleep restriction, stimulus control, and correcting dysfunctional beliefs about sleep. Numerous clinical trials have demonstrated that CBTI is not only effective, but often yields more durable, long-term results than hypnotic medications, all without introducing the risk of chemical sedation, physical dependence, or accelerated cognitive decline. Similarly, CBTA teaches patients to identify, challenge, and modify the thought patterns and avoidance behaviors that sustain anxiety. This approach builds internal coping mechanisms and promotes neuroplasticity, fostering genuine emotional regulation and resilience. By teaching the brain to self-regulate and adapt, CBT fundamentally addresses the underlying cause of distress, offering a path to improved mental clarity and reduced reliance on pharmaceutical agents that compromise the cholinergic system, thereby safeguarding the patient's long-term cognitive health. The pervasive concern surrounding age-related memory loss often overshadows a critical truth. Not all cognitive decline is permanent, and decline stemming from pharmacological burden is frequently reversible. This chapter serves as a powerful concluding assertion of empowerment and neuroplastic resilience. It synthesizes the information from preceding chapters to underscore that when the cumulative burden of high-risk medications, specifically anticholinergics, sedatives, and nutrient blockers, is systematically and safely removed, the brain demonstrates a remarkable capacity for functional recovery. Deep prescribing, when executed correctly via gradual tapering and substitution with safer alternatives, often results in tangible, measurable improvements, enhanced alertness, restoration of short-term memory function, and increased emotional clarity, sometimes within weeks or months. This observed recovery provides compelling clinical evidence that a significant portion of what is often labeled early dementia or age-related mental fog is, in fact, drug-induced cognitive impairment, DICI. The successful management of DICI requires a proactive partnership between the patient and their geriatric care team, leveraging the knowledge of the Beers criteria and anticholinergic burden scoring. Ultimately, the narrative shifts from fatalistic acceptance of decline to an optimistic mandate for vigilance and active medication stewardship, affirming that safeguarding the aging mind is a highly achievable goal rooted in informed therapeutic choices.